without any interaction with you guys. Um, but that's what the policy is. And I am hoping that we will soon start tutorials which will be interactive by my team, my assistant professors and registrars and resident. I have asked Bakti Saab and he has allowed me. Okay, so far almost half of you have come, 51. We will begin. So as you can see from this slide, we are going to discuss the malignant tumors of the oral cavity and oropharynx. More or less, the presentation are a little bit different, but the management is same. So it says oral cavity, but it also include oropharynx. I hope you know the anatomy of the oral cavity and oropharynx. And so what are the various malignant neoplasm of the oral cavity? If any one of you knows, just start writing on a sheet of paper so that you know where you stand. The commonest malignant tumor of the oral cavity is squamous cell carcinoma. And as you know that oral cavity is lined by squamous epithelium, but there are other structures, minor salivary gland, mucous gland. So sometimes the tumor arises from those glands, which could be adrenocystic carcinoma, adenocarcinoma, occasionally sarcoma. These are rare tumor and lymphoma. I always tell my patient that if the diagnosis is lymphoma, then it is a relatively good news because uh, they do not need major surgery for lymphoma. Obviously, they need chemotherapy and perhaps radiation. Okay, so next slide is about the sites of the oral cavity. In Pakistan, the commonest site is buccal mucosa, not tongue. If you review the international literature, they mention tongue is lateral border is the commonest site, but in Sindh and Karachi, we see the cheek, buccal mucosa, which is the commonest site. Other sites which are visible, which are involved are alveolus, mostly lower alveolus, floor of the mouth, lips. So these are the common site of the oral cavity carcinoma. These are the pictures of my patients, and this is just to show you how they various tumors at various stages presents to us, and look at all these pictures very carefully. Okay, heart palate. Mostly they may be arising from the squamous epithelium or salivary gland, or the tumor may be coming from the maxillary sinus and involving the heart palate. This is one of the last slide shows this arising from the heart palate, and you can see this whitish patch, whitish thing, which I would have asked you in the interactive lecture. Okay, so in the oropharynx, I hope you remember the anatomy when I was giving this lecture last year. A lot of students did not know what structure lie in the oropharynx. Tonsils, okay, posterior one third of the tongue, posterior wall of the oropharynx, and the soft palate. These form the sides of the oropharynx. Fortunately, the tumors in this area are not as common in Pakistan as in the West, where human papilloma virus is the culprit. In Pakistan, HPV virus causing the carcinoma is rare because of our healthy practice. So the tumors in these sites we do see, but they are not as commonly seen as in UK or USA or Europe. Okay. Now, predisposing factors, as all these, I've shown you so many pictures, and really, this is a grave concern. The Chalia and betel nut practice is so common in Karachi and Sindh. And as you know, we are going through this pandemic of coronavirus, but this Chalia and causing carcinoma of the mouth is another grave crisis which I am witnessing over the last more than 2 decades uh, in Karachi, and especially the incidence has increased tremendously alarmingly in the last 10 years, and we are seeing in young adults. The youngest I saw a carcinoma of tongue was 16-year-old girl, and she presented at a very advanced age, and the family who came with the girl were the mother and the brother. They were both were eating chalia and they refused biopsy. So this is the state of affair in our province and Karachi. And as a student, it is your duty to, if you see somebody involved in these habits, please ask them to quit, because this has got a very detrimental effect uh, on their body. Okay, so these are the predisposing factors. There is a difference between predisposing factors, predisposing appearance, which are leukoplakia or erythroplakia. So these are the predisposing factors. Okay, right. So next slide is about pre-malignant lesion. The previous slide shows predisposing factors. In the exam, when we ask questions, the students get confused between pre-malignant lesion and predisposing factors. So predisposing factors are different from the pre-malignant lesion. And I'm sure most of you, the commonest pre-malignant lesion for oral cancer is leukoplakia. This is the slide showing whitish patch, and sometimes you cannot differentiate between leukoplakia and the fungus which is called thrush, which is caused by candida in the oral cavity. So if you cannot differentiate clinically between the two, you put on glove and scrape it with your finger. If it is thrush, it will scrape off, but if it is leukoplakia, it will not scrape off. It will be a bit thick. So this is how you differentiate between of the white patch in the oral cavity between leukoplakia and the thrush. Another is erythroplakia. The chances of malignancy in erythroplakia are more than leukoplakia. Both are sinister, but if you compare the two, erythroplakia is more sinister pre-malignant factor. Next is lichen planus. It appears like a grayish-white area in the cheek, surrounded by a little bit of hyperemia. It is not as uh, white as the leukoplakia. This is lichen planus. And old submucous fibrosis. Was something which I never saw during my training in UK. This was the first time I saw it in Karachi when I was examining a patient. I had no idea what it is. And my registrar, uh, who is now, I think, associate professor, told me that this is a submucous fibrosis. So I did not know it 28 years ago, but now I have seen so many patients with submucous fibrosis, which is a pre-malignant lesion. And these are rare causes, so you do not have to remember them, but please do remember these top four. Okay, I'm going to show you various slides, and this you have already seen. This is another on the tongue, and sometimes you get confused, as I said, between leukoplakia and thrush. So scrape it with your finger and see if it is leukoplakia or thrush. This is a closer slide of lichen planus. This is submucous fibrosis. Okay, so how do they present clinically? I'm sure you all know this. In the previous lecture, painful mouth or sore throat, I told you what are the various symptoms. So obviously, it can be symptomatic, and sometimes it may be asymptomatic. The commonest presentation is usually pain in the mouth or sore throat, or patient says that I've got ulcers. Ulcers in the oral cavity is a very common phenomenon, and all the ulcers are not malignant. But please remember this: any ulcer in the oral cavity or oropharynx, if it has not healed in 4 weeks, you must, I will repeat, you must recommend a biopsy. Now, in our society, unfortunately, educated or uneducated, they are scared of biopsy because of various myths. So they will not come for biopsy. I have seen so many patients when they came to me with stage 1 with a suspicious oral cavity carcinoma. I advised them to get a biopsy. They disappeared and reappeared after 3 to 4 months with stage 4, and even sometimes stage 4B, which is an inoperable. And I get so annoyed. So these are various myths. people do not come for biopsy, so you have to convince them. So any non-healing ulcer, if present there, this and with experience, you know whether it is malignant or not. But it's still, if even if it looks benign and in 4 weeks it is not healing, it is better to do a biopsy. This looks like a small white, grayish white ulcer base. Clinically, it looks benign. But if even if this kind of ulcer is not healing, it is better to do a biopsy. There may be a tumor deep. Okay, it can appear as a fungating mass, which is obviously quite obvious. And even if somebody has got a fungating mass, you don't have to wait for 4 weeks. You straight away go and do the biopsy, like this one and like this one. Okay, now a lot of people comes to us that they had a toothache, they went to dentist, the dental surgeon removed the teeth, but my pain is still there. Now, if the dentist is a clever one and have examined his gums properly, then he should or would have picked that the cause of toothache is or loose teeth is not the teeth itself, but there is a surrounding tumor. And if they do a proper examination, then they can uh, detect this. But sometimes dentists miss those, and these patients disappear, and then they come with a big tumor arising from their gums or alveolus. So anybody, I'm not saying that everybody who's having toothache or loose teeth has got a malignant tumor, but there is a strong suspicion uh, should be raised in your mind, and you should examine their gums and mouth very carefully. The examination, as in every case, I always emphasize history and clinical examination is a must. Even at my stage of more than 35 years experience, sometimes if I miss a question in the history or clinical examination, I miss a diagnosis. So there is no alternative to history and clinical examination. Even the advanced investigation sometimes will not help you. But if you have taken the good history and clinical examination, and believe me, your diagnosis would be very easy relatively, and you may get a diagnosis even without the investigation. These investigation only supplement your diagnosis. You will, those in all cases will not give you the diagnosis. In some cases, yes, the tumor is not visible and maybe it is deep, lying submucosally in the back of the tongue, and you are not able to palpate it, and it is not visible with endoscopy, so it will be visible. But in most of the cases, uh, uh, history and clinical examination will be very helpful. Okay, coming back to the topic. So this again you see coming from the lower alveolus. Patient had a toothache and somebody removed his lower, I think, first premolar. But if you look carefully, there is an ulcer. So any ulcer or thickening or swelling or a mass near the loose teeth is an indication that it could be malignant. Okay, red patch is white patch. So these can be the clinical presentation. Sometimes they can they will have absolutely normal oral cavity, but they will present with what? Think and write down on the piece of paper the answer. They will not have any symptom of the oral cavity or the mouth or anything on examination, but they will present with think nodes. Okay, cervical nodes. Sometimes patient may have got an occult primary. That means primary is hidden, but they come with the cervical nodes, neck nodes, especially at level of 1, 2, and 3. Okay, so these are various presentations in the oral cavity, ulcer, fungating mass, ulcer near the gums, and sometimes they're present with this very advanced tumor with the fungating mass on the cheek, okay, or the skin of the chin, or the cheek, or the face, right? Now, this is lymph node, which is obviously visible on inspection, but sometimes lymph nodes are not visible on inspection. You have to examine the neck. So whenever you examine the oral cavity, oropharynx or larynx, neck examination is a must. This is an question we often ask in exam. So please do not forget the neck examination. Okay, so sometimes they present with trismus, that is locked jaw. They are unable to open the mouth, and like in case, this is my patient. He could not open the mouth because of the trismus. The reason for trismus is that because of the tumor, which is so extensive that it has involved the muscles of the jaws, pterygoid muscles, masseter muscles, and so they are unable to open the mouth. So these people can present with this trismus, very occasionally with bleeding, and sometimes with odynophagia if the tumor is involving the posterior pharyngeal wall of the oropharynx or back of the tongue or tonsil. So they will have complaint of painful swallowing. All right, odynophagia is painful swallowing, dysphagia difficulty swallowing. So these are the various clinical presentation. You must look at this slide carefully. Now, next slide, I'm going to show you various pictures. There may be repetition. This is one of my patients. Look at this. Horrible. I think I remember he came with this mass, which you can see this fungating mass, and there is swelling, and even his neck node are fungating. So if they refuse the biopsy and they come late, they go for the alternative treatment, homeopath, hikmat. A lot of people go get the homeopathic treatment. I tell them, look, I do not mind if you have got subtle symptoms like rhinitis, allergic rhinitis, or something which is a medical treatment, which is not sinister. You go for homeopathic treatment, fine. But I think if something like malignancy, the treatment, unfortunately, they do not have the treatment. I am not against homeopath or Hakim. They have some alternative medical treatment for a lot of medical conditions. And but there are some but there is a limitation. As we also have limitation, sometimes when these patients comes to a with a very advanced stage 4B, which I will tell you what stage 4B is, then I will tell them that look, this is inoperable. So we have to be honest. Unfortunately, people who are dealing with alternative medicine, they give a false sense of security to patient, and they say that they can cure it. This, I think, is very unethical. There's another patient with fungating mass. This is a silk stitch. This is post biopsy. This is not my patient. This is tonsil tumor. This is also I think was one of my patient, probably presently with the mass in the back of the tongue. And this looks sinister, and we did the biopsy. This is another picture. You have already seen this picture. This is again my patient. You can see the ulcerative lesion in the soft palate and the tonsil region. Okay. And if you are not careful in depressing the tongue or not careful in examining the mouth, you can miss this. So proper examination. So diagnosis is done obviously by, you know, that by history, clinical examination. When you are doing a clinical examination, obviously local examination and neck is very important. You examine all parts of the oral cavity, like you ask a patient to open the mouth, first see if there is any trismus. Trismus can be various stage. They can partly open the mouth. So we grade them, grade 1, 2, 3, 4. It is written in the books, so you can read from those books. So normal patient should open the mouth for about more than 4 centimeters. Okay. If you open your mouth and you put your fingers between upper incisor and lower incisor, so you can see it is 4 centimeters or more. Okay, so local examination, you examine the mouth systematically, examine from one side, like first ask the patient to open the mouth, and then ask them to protrude the tongue. If they are unable to protrude the tongue, then it means that tongue is fixed. So there is a possibility that there is a great possibility that the patient may have a tumor involving the tongue or the floor of the mouth. That is why they are not unable to protrude the tongue. So this you are doing inspection. Then you inspect the cheek, both cheek, floor of the mouth, palate. So this is what is clinical examination, and you can see my video which is available in the library. and you must have seen during the third year. Or there are various video available in YouTube. I'm not saying that you should see my video, any video which with which you are comfortable, but you must know how to examine it. And obviously, you do a general examination to assess the general status or health of the patient, because if you're planning major surgery, you should know various comorbid like the patient is suffering from ischemic heart disease or hypertension or diabetes or any other medical problems, any COPD. Okay, so you do the biopsy. And again, this is a common question we ask you, which part of the tumor you will do the biopsy? You do the biopsy from the edge, not from the center, because in the center there may be necrosis. You do the biopsy, you send to the laboratory, and the laboratory reports that there is a necrosis and you have missed the diagnosis. So you must do from the edge of the a ulcer or the tumor. This is a very important point. Edge of the lesion. This question is often asked in MCQs in the oral, so please do remember it. I hope I'm not going too fast. You can put various questions on Edmodo later if you have any. Now, what are the various investigations you should do if there is an obvious malignant tumor in the oral cavity like this one, or in the previous picture which you have seen? Then you can do the CT scan before the biopsy. But if you are not sure, you do the biopsy first and do the CT scan. Now, often students ask which is better, CT or MRI. Okay, in the oral cavity, if the tumor is not involving the tongue, if it is involving the cheek or the alveolus or the palate or the floor of the mouth, we do ask for CT scan, because we would like to see whether it is involving the mandible, as in this case, this is a tumor and it is causing the lower cheek and arising from the lower alveolus, and it has caused the erosion of the mandible. However, if the tumor you see only limited to the tongue, then you would like to see the extent of the tumor posteriorly, how far posteriorly it is going, and in the soft tissue, and if it is not involving the cheek or the lower alveolus, then MRI would be a better investigation than CT. So in the tongue tumor, you do an MRI, otherwise you do a CT scan. All right. Okay. So there are obviously when we talk about investigation, we do some general investigation and local investigation. These are the investigation which you do when you are planning um, some biopsies. You just only do CBC, complete blood count. But if you are planning a major surgery, you have reached the diagnosis and consult the family and planning the major surgery, then you, apart from the CBC, you do LFT, urea electrolyte, hepatitis B and C. Blood gases is not always required. I think I should change this. However, urea, creatinine, and electrolyte is important. So, and chest X-ray, you see there it is, urea, creatinine, electrolyte, and chest X-ray. To assess why we are asked you in the exam, you say chest X-ray. I will ask why you want to chest X-ray in a patient with this tumor or this tumor. There's no history of pulmonary problem, but you want to do it. The answer is that you would like to have a baseline investigation, because post-operatively patient develop some pulmonary complications, so you know the baseline. Secondly, sometimes patient has got a metastasis. Now chest X-ray can show the metastasis, but in more than 30-40% cases, chest X-ray will not show the metastasis. However, it is good, it's screening investigation, and before general anesthesia, you must do the chest X-ray as well. Now, these are the general investigation. Specific, I have already talked about a little bit earlier, and CT oral cavity and neck. You must include a neck to see the neck node. With contrast, so why do we do the contrast? So I see now there are 96 participants. Okay, I welcome those who have joined late. I would request you to please get up early in the morning and join earlier. It is better to begin the lecture. Now there is no excuse that हमारी bus late हो गई थी या हमारा traffic बहुत था. So you people are sitting at home in your bedrooms or in your living room, so there is no excuse to join late. I joined this at 10 o'clock. I was with the screen. That time was 10:15, but I opened my Zoom at 10 o'clock. So I request you to join on time. All 96 of you should have come at 10:15. So please make sure next time. I am very particular about the timing. And during the normal lecture, if somebody comes 10 minutes late, I do not allow them in the lecture hall. Uh, so now it is showing there is someone enter the waiting room for this meeting. I think I'm not sure whether I should allow them. As an exception, I will allow them to enter to join the meeting, because but from next time I will not allow anybody who uh, join the Zoom after. I will give you five minutes grace period, but you must open your Zoom 10 minutes before the lecture starts. Okay, please allow those who are late only this time. This was the point. Not, this was the point I'm trying to make to all the students. Please, why you are joining at 10:40? Now this is really annoying, and you have disturbed the whole class. You are joining at 10:40. You are sitting at home. Wake up early. Put on alarm. Ask your parents or somebody to wake you up. You people are responsible adults. You are not KG class children. Please do not. Now there is 99 now. So this shows the lack of interest or lack of irresponsibility in some of you, and I'm really getting annoyed with this. Anyway, I'm sorry with the rest of the students who was on time that I had to say this, but I thought I must pass a message. Please come on time. Now, CT scan oral cavity with contrast. Now, I don't know how many of you know the concept of contrast. We give various contrast agent to highlight the tumor. If it sometimes radiologist is unable to detect whether the extent of the tumor, because when we give the contrast, it is highlighted. When it is highlighted, so they can see the extent of the tumor. If it is not contrast, then uh, the radiologist may not be able to give you the extent of the tumor, because why we want to do the CT scan in this case? Obviously, this is a tumor, but I would like to see whether it has gone beyond this side to the base of the skull or pterygoid muscles. So as in this case, you can see it is involving this buccinator muscle, but it is not involving the medial pterygoid here. Now, how do you know this? Simple. You look at the blood vessels. These are the major blood vessels, carotid and interjugular vein. They are white color, opaque. That means this is a contrast. Okay. So CT scan with contrast. And why this slide is not moving for some reason. Yeah, MRI scan oral cavity and neck with contrast. I told you earlier, when the tumor is limited to tongue, then you do an MRI. All right. And then we have talked about the biopsy. So when somebody asks about what investigation you will do, so you should know that there will be general investigation and specific investigation. If you are only planning to do a biopsy, then you can do the CBC and Hep B and C and do the biopsy. But if you are planning a major surgery, then you also have to do urea electrolyte checks, X-ray, maybe LFTs, and in occasional cases when patients have got severe pulmonary disease like bronchitis or asthma, then blood gases. But this is not required in all cases. And specific investigation we have talked. Okay, so far so good. Next, please. So why do we investigate? You say, Dr. Shigli, this is obviously tumor. Why you want to do a biopsy and waste patients' time and money? You are partly right, because we know that majority of them are squamous cell carcinoma. But occasionally, especially in the palate, in this region like tonsil, soft palate, back of the tongue, it could be a lymphoma. So if it is lymphoma, and you do a major surgery and it turns out to be lymphoma, then you obviously this you would not be looking yourself with pride. So biopsy, however, sometimes when we see the patient very large tumor involving the cheek, I will show you the picture of face with erosion of the bone on the CT scan. We know it is obviously tumor, and the patient is reluctant. Then we do not do the biopsy. But I think for this is individual judgment on individual basis. But from your point of view, at your stage, you do investigation to confirm the diagnosis and to see the extent of the lesion. So obviously on examination, you have got some idea of the extent of the lesion, but there are certain areas in the oral cavity and pharynx where you can see the extent of the lesion with the CT scan or MRI. And why you want to do the see the extent of the lesion so that you can decide whether I can this tumor is resectable or not. So you stage the tumor, and also the advantage of staging the tumor is that whether this patient, in addition to surgery, will require radiotherapy also after surgery or chemotherapy after surgery. Remember, in oral cavity, the first line of treatment is surgery. Second line of treatment after surgery is radiation plus minus chemotherapy. So we want to see the extent of the lesion, staging, whether it is resectable, and also the general assessment like CBC. Patient is not anemic. Patient is not suffering from any thrombocytopenia. So these are the three reasons for investigation: to confirm the diagnosis, extent of the lesion, so that we know what stage it is, whether it is resectable. Okay. Oh, right. Treatment plan. Now we have got only 15 minutes left. I must rush. Treatment. We have to plan the treatment. Once we have taken the history, examination, investigation, we have made the diagnosis. Treatment plan is the first is what? You have taken the history, the diagnosis there. So, what is your first step in planning? Counseling. You have to counsel the family and the patient. All right. Now this slide is nowadays is should not be showing, should not be touching the hands nowadays. And I think in next in the near future, we will not be touching the patient's hand without wearing the gloves. All right. Anyway, counsel the family, be sympathetic because this is a grave news which you are going to tell them. Curable, and the plan is first is counsel the family, and after history examination investigation, you decide whether it is curable or not. For example, the patient may have got a metastasis. The metastasis is very rare. So in the oral cavity tumor. So, but if it is metastasis, then obviously it will not be curable. All right, resectable or not. So you are this is you are thinking, okay, whether I will be able to remove the tumor. When I say resectable, whenever we are doing the tumor surgery, sorry, we must we must remove the whole tumor with 5 millimeter margin. If we cannot do that, then there is no point in doing surgery. So these are the factors. So you counsel the family, assess mentally whether it's curable, resectable, and the general assessment of health. If patient is 90 plus or 80 plus with a very poor health, obviously I will not operate even if it is resectable or curable. The general assessment. Okay, so what you do in the counseling, you break the news gently. Obviously, this is a very alarming news for the patient and the family. So you learn the counseling with practice. You are in fourth year, and there are various workshops available for you to learn counseling. This is an important aspect of your of medical student to learn counseling. Nature of the disease, you have tell the patient the prognosis. What is the prognosis? Is he going to survive the treatment or not? And what are the treatment options? Obviously, nobody wants surgery, but you have to tell them treatment option, the advantages and complications of treatment. There are always some complications, and the rehabilitation, especially the oral cavity and the pharynx. If you are doing a major surgery, so they would like to know if you are doing a hemiglossectomy or total glossectomy, what will be their speech like? What will be their swallowing? Will they be able to swallow food? All right. So these are the points in which you consider in the counseling of the patient with tumor, be it the oral cavity, pharynx, larynx. All right. Now this is staging. It is visible. It is given in the books. I will give you quickly. You have to remember in the primary. You remember 2 and 4. Less than 2 is T1. Between 2 and 4 is T2, and greater than 4 centimeter. And T4 is involvement of skin or mandible or maxilla or deep muscle. Okay, and in the lymph node, you remember these two figures 3 and 6, and one is less than 3, and 2 is 3 to 6, or if they are bilateral, multiple, or contralateral, and 3 is 6 centimeters, more than 6 centimeters. All right. Okay, treatment option, as I said, primary, in most of the cases, we do the tumor. This you can see, although the tumor is not fungating the skin, but it is very close to the skin. On the examination, you can appreciate not from this, not from on this picture. So we have marked this tumor, and this is the margin we are going to remove with the tumor, 5 millimeter at least. I prefer 10 millimeter because they shrink after surgery. So minimum 5 millimeter, ideally 10 millimeter. And we send them when we do the primary, we send them for frozen section whether we have completely removed the margins or not. If the report frozen section, which is the biopsy report which comes within a half an hour, if the pathologist says no, your margin is very close, less than 0.5 centimeter, we remove more tumor, and then we do the neck dissection. There are various type of neck dissection which you can read in the book, and reconstruction. So these are the three elements of surgery: excision of the primary, neck dissection, and reconstruction. All right. This is a patient you can see. This is my patient. Look at this tumor. But fortunately, it was not going posteriorly. It was all anterior. But look at the size. This is a very small picture, and look at this side. And I did a very major surgery, and the plastic surgeon put a flap, pre-flap. Although cosmetically this is not ideal, but I'm sure you can appreciate that this is better than this. This is pre-op. This is post-op after a few months. Okay, so you can see we see these type of patient, and a lot of people gasp when they see this patient. Okay, okay. Post-operative radiation and chemotherapy is never used as a primary treatment in oral cavity. In oropharynx, when it is arising from the tonsil or soft palate of back of the tongue, and if it is T1 or T2, we consider radiotherapy. But in the oral cavity, in the mouth, surgery is the primary treatment. In the mouth, surgery is the primary treatment. And post-op, you give radio and chemotherapy. If the margins are closed, it's stage or T3 or T4. All right, stage 3 or 4, you always do post-operative radiation or chemotherapy. All these three patients are discussed in multiple disciplinary team meetings, which is called MDT meeting or tumor board. And then we decide the plan of the treatment. So when it has become inoperable, I mentioned in the beginning T4B. So what is T4? T4 is greater than 4 centimeter, or if it is involving the skin, that is operable. If it involves the mandible, that is resectable, operable. If it involves the maxilla, that is still operable. But if it involves the pterygoid plates, infratemporal fossa, paraphageal space, this becomes inoperable. Okay, that is why we do the CT scan. Or if the node is such that it is surrounding the carotid 360, so obviously we will not be able to separate from the carotid, so it becomes inoperable. Or if it is fixed to the prevertebral fascia, the mass in the neck, this is talking about neck mass, is fixed. If it is fixed to the prevertebral fascia, that means it is fixed to the prevertebral muscle, that is scalenus anterior, medius, posterior, or splenius muscle, then we will not be able to completely remove it with a good margin. So if you cannot remove the tumor with a 5 millimeter margin, then it is inoperable. So in summary, early diagnosis is the key. You do a biopsy of non-healing ulcer. If it is non-healing in 4 weeks, I said in the beginning, this is for the latecomers. So you must stage the tumor. What stage is it? So that you can plan the tumor treatment. And when you're planning, counseling of the patient and the family, and the planning of the treatment. All right. So in the end, this is to emphasize that beetle chalia, all sorts of these addiction should be stopped. Smoking as well. In the West, I saw a lot of patients where when I was working in UK with oral cancer in Scotland, in Glasgow area, and they were heavy smokers and alcohol. Fortunately, alcohol is not uh, uh, common in our society. But in the West, alcohol and the smoking, and in our society, especially Sindh. My colleagues living, practicing in Punjab or KPK do not see so many oral cancers as we see in Sindh, and also now it is affecting some areas of Balochistan. So please